Hi everyone, today we are lucky to talk to Dr. Magnus Hald, Director of the Division of Mental Health and Substance Abuse, University Hospital of North Norway in Tromsø. Among other things, he has been closely involved in the development of a medication-free unit within the hospital. Today we're going to be talking about his unit and also about what's been happening in Norway since 2015. Just to remind you, in 2015, the Norwegian Ministry of Health issued a directive on establishing medication-free wards in the country. Magnus, I first heard about the 2015's directive after reading Whitaker's overview of the debate that happened in Oslo in 2017. Then I found the video of the event and watched it from start to finish with truly great interest. Now I have to say that Norway has a very special place in my heart. I actually lived there between 2011 and 2014 and did my PhD at the University of Bergen. Um, I remember the first time I visited psychiatric wards at Stavanger University Hospital, and I must admit that my Russian psychiatric mentality was shaken back then. Before my visit, I had no idea that there are some places in the world where psychiatrists do not wear white coats, where you can just sit and have lunch with patients. So I was really impressed, and this time again, Norway continues to amaze me. Could you please tell us what was happening in Norway before 2015? What eventually led to the Ministry of Health directive on establishing medication-free wards in your country?
First, I would have to correct you on one point. I'm no longer the director of the mental health and substance abuse in the University Hospital of North Norway. I resigned from that position by September last year, and now I work full time for the last few months as a psychiatrist in the drug-free treatment unit of the hospital. So, but I was also here. I was the director when this unit was established in the hospital.
Right.
So a little about the background for the establishment of this unit. There was for a long time different users and user organizations in Norway have been very occupied with the lack of treatment choices for people, especially people with serious mental problems in the Norwegian mental health system. So they've advocated for the possibility to develop different treatment options. Amongst those, a drug-free treatment option, or at least an option where drugs is not a central part of what's offered. And different people and different organizations have argued for this for quite some while. And and the arguments about this have very often been introduced into the debate about coercion in psychiatry. And the idea here has been that if you can give people other options than drugs, maybe that would help reduce forced psychiatry or coerced psychiatry to some extent. So that's been one of the ideas behind drug-free treatment. Then the government would generally say, well, all you patients seems to disagree on this, the organization seems to disagree, so they didn't really take this to heart that we needed this kind of possibility. But then around 2010-11, almost all the different user organizations or advocates organizations in Norway united and made a common attempt to achieve a drug-free treatment option. I think it was almost all the different organizations except the one for ADHD, which sometimes seems to think it's a good idea to have more drugs. But all the other ones in Norway united and agreed on we need this. And they argued about this to the health minister in the national government. And in Norway, you have what it's called I don't really know the English word. You have a document that's sent to each health trust. As you might know, in Norway, the specialized healthcare system is organized basically in 4 different national health trusts.
Yes.
It's a northern one, mid-Norwegian one, the western one, and the one in the southeast of Norway, Oslo region, and the region around that. And the health minister, he said that all of these health trusts should have at least one place that could offer a drug-free treatment program. And this was in this document that the ministry sent to the health trust every year. They send a document telling the health trust what to do. This is, you know, a kind of new public management administration of healthcare system. You get the order every year. This is what you're supposed to do, and then you have to figure out how to do it.
And until 2015, it was mostly a suggestion to start that.
No, it was not a suggestion. It was actually a command, but nothing happened. So by the time of 2015, the health minister said, "Well, we can't. I won't deal with this anymore. You have to do it." Right. And he gave a specific order. On the side of this annual document, he also sent a special letter to all the health trusts and said that each of you will have to develop at least one unit that offers drug-free treatment, and for the Southeastern Health Trust, they should develop 2 units because they're much bigger health trusts than the other ones. And so that was an order given in late 2015, since nobody had done what they were supposed to do before then. So that was the background for the establishment in Norway. So it was an initiative by user organizations. It was not an initiative by psychiatry itself or the mental health field itself. Absolutely not. It was a user perspective that came up with this suggestion, and that made it possible to move in this direction.
How would you classify these organizations? Do you feel they were at least partially represented by anti-psychiatric organizations, or there were different kinds of them?
No, all these organizations that united, they were user organizations. So they were organizations by former patients, families, things like that. So they're all that kind of organizations. No organizations with professionals in them at all. Or maybe some professionals would be members of some of these mental health organizations, but they're not professional in itself. And it's also, since then, it's been, you know, a central question, I think, in the debate has been, how can you regard user knowledge compared to what you might call the knowledge that you have within the professional field? How can these 2 different kind of knowledges be looked upon, evaluated? And is it so that you know, the so-called professional knowledge is superior to the user knowledge, or is it what are the arguments for regarding different kinds of knowledge?
Indeed, I entirely agree that this is a central question in this debate, and some of my colleagues immediately commented that the mere idea of offering an opportunity to choose treatment options for someone, for example, in a psychotic state experiencing delusions and hallucinations, presents a challenge in psychiatry. So we definitely need to figure out how to address these issues. For example, is it ethical to allow someone in a psychotic state or a relative of a person who is in a psychotic state to choose whether he or she needs a medication at all, and how and when such a choice should be made, by whom? What is your stand in this debate?
Well, in my opinion, we have many problems with the kind of treatment offers that we give patients in mental health. In my opinion, generally it should. I mean, the rules are the same within the mental health field as in the rest of the healthcare system. That treatment is optional. If you want treatment, you can get treatment, and if you don't want treatment, you don't have to have any kind of treatment. So the question in psychiatry will be: are there patients that are not competent to evaluate this? And when patients are not competent, how should this be evaluated? So that's, I think, is the question. And I think that it's a difficult question, because what does it mean to have the competence to agree? Some doctors seems to think that it means that, or to choose. Some doctors seems to think that, you know, the patient is competent if she or he agrees with me as a psychiatrist. But of course, in Norway, there has been a lot of debate about competency and how that can be evaluated.
Yes, indeed.
There's a system now that we have to evaluate competency for everyone that receives psychiatric help in Norway.
Indeed. Should we automatically assume that every psychiatrist is competent enough to make these sorts of decisions?
Well,
Yeah,
it should. Yeah, basically, that's how it's supposed to be. But
yes,
it's a very difficult evaluation to make, and it's hard to say when are you competent enough. Because for instance, it's very clear in Norway you may not be competent, for instance, to say that you need or don't need psychiatric care, but at the same time you may be competent to say whether or not you want drugs.
yes.
So competence
Interestingly,
can be different things.
Interestingly, when preparing for this interview, I felt very clearly how sensitive the topic of drug withdrawal is in psychiatry in general. I didn't expect such a polarization, and I didn't experience such a polarization even when discussing medical application of psychedelics. And I can imagine that before the mandate, it was even harder to talk about it. It's still hard to talk about it. I could see that when preparing for the interview, listening to my colleagues. Yet, I think very few psychiatrists would deny that the problem of over-medication is real. Adding to this, a huge proportion of our patients stop taking their medications within a year by some sources to up to 74%. We organize workshops, conferences on drug adherence with very limited efficacy. Um, and you said that some of your colleagues reacted differently to this directive. And for example, some of your colleagues in southwestern Norway believe that such a step, I'm quoting recent article by Jason, can exacerbate negative attitudes towards medication and further worsen already existing adherence issues. Do you agree with this statement?
I think this article is a very interesting article, and it's when you read the article, you can see that no psychiatrist in this hospital in south western part of Norway has any positive is quoted in any positive way about any aspect of the drug-free treatment possibility. To me, this article is an example of what happens when you write an article where the authors and the participants kind of um, share the same. They share the same. What should I say? They have the same ideas on beforehand, and they don't question their ideas at all. This is a so-called qualitative research article where generally in that kind of qualitative research you should kind of in your research develop some kind of hypothesis or whatever that you would investigate, but they already have their hypothesis. They don't question. I mean, they have a statement in the beginning where they say that it's very clear that neuroleptics, I guess they call it antipsychotics, have a good effect on short-term, at least a good short-term effect on psychosis, which is a questionable statement.
I see.
So I think they have a lot of biases when they write in the beginning when they write this article. And it's to me it's very interesting that they don't have a single positive statement from anyone. But they have statements like there will be more crime in the streets if we get this kind of option, which is what and they argue a lot about science. What kind of science says that there will be more crime in the streets if you have this option?
Yeah.
So this article, I think, it's very strange to me how someone could publish an article like this. It's because it's yeah, it's not really understandable.
I see. I'll also ask you a few questions about biases when we're going to be talking about perhaps the role of the big pharma in psychopharmacology, in modern psychopharmacology at least. We know what's been happening with SSRIs, for example. There were several meta-analyses that showed clearly that if a first author is associated with the pharma industry, then he or she is 20 times less likely to report any negative outcomes of the treatment. Uh, and speaking about this situation in particular, there is about the use of antipsychotics. There is an ongoing debate, of course, on mortality risks associated with antipsychotic treatment. A series of population-based studies of patients with schizophrenia by Tihanen's group showed that antipsychotic treatment is associated with lower mortality, But there are also new studies showing the opposite effects on antipsychotic medication in older individuals, especially those suffering from dementia. How important do you think these studies are? I'm referring to population-based studies mostly for informing policy making. Do you think we still need to conduct, well, I would still call what your line of research an experiment to see what actually happens once our patients start to withdraw the drugs in a clinical setting?
Yeah, I think all kinds of research in this field is very important because it seems like you're referring now that we get very many different results, or the research can be interpreted in very many different ways. It seems that some of these articles, for instance, the article you mentioned earlier, some of the research that they're quoting, for instance, supporting the good effect short-term treatment with antipsychotics, can also be interpreted in different other ways when you look at the articles. So this, to me, it seems that we have in a situation where the knowledge base, the scientific knowledge base is in somewhat shaky. It's even more important to have the possibility for the individual person to make his or her own choice.
Yes, indeed. Yeah, I entirely agree with this. And for example, people who perhaps withdraw or stop taking medications, or let's take the opposite population of patients, those who are more likely to adhere to the treatment in general, all kinds of treatment. We see that consistently in different kinds of research, they do better in the long term. So you really cannot tell to be conclusive from the studies of this sort. So I think even
No.
though, as I said, this debate seems to be very polarizing in a psychiatric community, I think all of the colleagues who I talked to, they all agree that it is an interesting and an important experiment because, if I understand it correctly, it's still relatively small scale. So, for example, your unit has six right? Six beds for the patients.
Yes.
And now I would actually like to switch our conversation to your unit specifically, because I received tons of practical questions from colleagues. But what essentially interests all of them is what a medication-free treatment of psychosis actually entails. Could you talk a bit more about your unit, the medication-free unit? It was opened in January 2017, if I understand correctly. And how
Yes.
does it look now? What kind of patients are being treated there, and what are the provided treatment options?
Well, from the time when we started, we would have liked to have a research project going on with the patients, and that's been difficult to establish. But now it's going to be established by this fall. We will have a research project that can tell more systematically, or can answer these questions somewhat more systematically than I can now. But to me, it seems that we have different groups of patients. We were not supposed to take patients that need coerced treatment, and patients should be able to make a choice. They should have the ability to make choices and be. So that's the group that we have will all have to be able to make an informed choice about the treatment that they want to receive. It seems that the biggest group that we have is a group that want to stop, that has used antipsychotic medication and that want to stop using it. And so we have a lot of patients that are tapering down their drug treatment. That will be the biggest group, I think, the tapering group. And there's not much, as you know, there's not much scientific knowledge about how to taper down medication in a good way. There is a lot of experience from former patients or from people that have tried to do it. You might know there have been some publications by user organizations or by different other groups that can give you some ideas, but generally we try to taper down very slowly. So we say that you need to taper down maybe, if you want to follow our suggestion, we would think very often 2 years, over 2 years, something like that. So this means that, and this also shows another thing when it comes to this ward, this 6 patients ward. We have a 6 patients ward for an area where there are about 500,000 inhabitants. So how to utilize these beds the best. So we try very hard to connect with the treatment system of the patients outside of the ward, so that we try to define ourselves just as a part of the treatment program for the single patients, and we try to develop the treatment program in close cooperation with the patient's family, local psychiatric services, GP, sometimes others. So we have these big meetings where we try to plan and try to find out how to go ahead with the program for each patient. So we try to tailor the program for each patient to the needs of the patient, together with the rest of the what we call the private and the professional network of the patients. So that's how we work, because if we were to have 6 places where people would stay for 2 years tapering down medication, we don't believe in that, or that would not be a possibility, or that would limit the number of people very much that we can treat. So generally a patient will come and stay, maybe, or the patient in this group will come and stay maybe 1, 2, or 3 weeks, and then related somewhat to where they are in the tapering situation, and then they will stay home for a while, and then they will come back and stay for another 2 weeks, and then so this is how it will. This is how the program will work for this group. Then there are some other patients that have never used neuroleptics, and that have symptoms of different kinds that also come to this facility, and some of them will need more time in the bed, in the inpatient situation. But there are so far not very many in that group. Most of the patients have used drugs before. There are very few that have not used, or that are not using drugs at all when they come in. That's a smaller group.
Can they still get a medication treatment if they ask to?
Absolutely. People don't have not or to stop using medication, but they generally will have to have an idea about reducing medication, or wanting to taper down, or not using medication, or they should get their program somewhere else.
It's important that.
So that's what we work with, and then
You mentioned that many people really want to. The problem that we don't have any guidelines or any scientific knowledge on how to withdraw from the drugs, or how to properly reduce the dose. There is a very limited amount of research in that matter, and yet this, judging by my experience as a resident doctor, that's the question that you receive so often every day from the patients, and it's really a shame that we don't have a scientific knowledge. So the patients don't get answers from their clinicians. They go on forums, they discuss it with each other. So I do agree that it is important to conduct studies like that. But speaking about the group that you were referring to, that perhaps, and you also mentioned that in the debate in 2017, that we have reasons to believe that there is a group of patients in psychiatry who perhaps don't need medication, but we just don't know who they are. My first question is, how do we have any information how big this group is right now? And in general, would you?
What do you mean, the group that doesn't need medication?
Yes. Essentially, to rephrase it, did you already, at least to some extent, start to answer the question what kind of group it is, and for example, in terms of the proportions, how many patients in the general population of, for example, patients suffering from schizophrenia spectrum disorders, do we have any information by now, or is it still too early to say this?
Well, I would say it's difficult to say that anyone really needs medication, but to me it seems that some people have a good use of medication in certain periods of time, or at certain places, or whatever. So I think that there are probably some people that can use medication, and that have a use of medication that's very acceptable and wanted. So I don't believe in totally getting rid of all medication. On the other hand, I think it should be up to the person herself to decide. And generally what we see when people taper down is that get more access to their feelings. The people that have used medication and then taper down, they generally report, both they themselves and also their families, that they get more access to their feelings, and that is generally experienced as something very positive. And people, I would think would be one of my biases, would be that many people would say that, you know, that they're more present in themselves, or that they feel more when they taper down medication. But even this has been a bigger issue than I thought it would be. I mean, this issue that, well, like one woman told me a couple of months ago, I thought my husband was gone. He hasn't talked to me like this for 4 years, but now he's back. I mean, this is a very strong message. And even whatever the direction this treatment will take, she knows that it was possible for him at one point to be back. So this creates some kind of belief in what's possible. So the one thing is that you get more access to your feelings, and the other thing is that some people also get more symptoms of different kinds. And then there's the question about how can you deal with symptoms? Should you treat the symptoms? Well, is it useful to treat symptoms with drugs? Sometimes people will stop tapering down, or they will say, well, I think it's better for me to try to control the symptoms this and this way. Sometimes people will say, well, I will have to find out. I can live with this. These voices that I used to be so scared of, they're not that scary anymore. We have talked about voices in a way that makes them more acceptable. So I can live with this, and I prefer to live with these voices instead of living with all the effects of the medication that I didn't like. So maybe this answers your questions a little about, drugs may be useful, but people consider it differently.
I'm glad you said this. I have to say that this is for the first time I hear this discussion and these comments from a psychiatrist, because when preparing for the interview with you, I interacted with some users of mental health care and their relatives, and they say essentially the exact same thing. I rarely hear that from a psychiatrist. And I think it is a challenge to try to connect the two aspects of a mental health care. Everyone should participate in this, and I think in general, mental health care is moving towards the direction of more collaborative work. So I think it is very important. You mentioned about experience of drug withdrawal in general by patients, by their relatives, but of course we talked about it before the interview with you, that we did have some experience in the past. For example, in the 60s, I'm referring to Kingsley Hall experiment, to Soteria House, but if I understand correctly, for the first time in the history, it is being implemented within the mental health care. Why do you think it's important to make a clear distinction between these sorts of experiments like Soteria House, Kingsley Hall, and what's been happening right now? What do you think is the most important distinction between these two approaches?
Well, at least we're trying to develop this, at least here, as what I would call a natural part of the mental health care system. We don't want to be,
Outsiders. You want to be integrated.
outsiders. We want to be insiders. So we try to develop it inside, and we try to develop it according to what the government told us to do. Although I'm not quite sure that if I got that amount of money and they said, well, you should use this money to work with the drug-free treatment program, that what I would do in this region is to establish a 6-bed unit. I'm not quite sure if that's what I would have done, but that's the option that we have. And I think I'm not sure. That's what but I think maybe to connect this so strongly with the bed unit, I'm not sure if that's really the way that we get the most out of the money. Maybe we could get more of it out of it if we work more outpatient-like, but I'm not sure. Because there are other beds, and maybe the other beds could be used also for this. And that also goes to another part of this program in Norway. The government also has said that all patients that are discharged from psychiatric care should have a plan for tapering down and eventually stopping using medication. This is to me, this seems to be a part of the governmental order that has not been followed very closely yet. So to me, it's also an important part for the unit that we have in this hospital to influence the other units in the hospital. And they know we're here. They know that we will talk with we will take over some patients. We will talk with them. We will agree on things. We will so we will be a part of the same system, and we can also influence the possibility of giving more drug-free treatment programs other places.
Is it a challenge to connect the medication-free approaches with the modern model of mental health care? Because I would assume that it's difficult considering the polarization of the discussion. Do you think that this model fits right now, maybe in the long run? How challenging is it to interact with your peers, with your colleagues who are more eager to expand or stick to the classical models of mostly pharmacologically focused treatment?
I don't think in this hospital there's not. This is not really a big issue. It seems that in this hospital, in my understanding, most of the psychiatrists here, they kind of think that this is one part of the hospital and this should be a possibility here. And I don't think. I think if you had given the questions that Yeltsin and others gave in southwestern Norway, that you would probably have some different answers.
So you think this model fits classical or modern model of mental health care, at least in the long run?
I think at least here it seems to do that. It seems to be possible to do that. But you never know, and I think it will depend a little on our ability to be seen as a positive part of the hospital. So we have to work on that.
I guess on funding
continuously.
As well, it depends directly on funding, how much funding you get to expand on this. And the next question that I wanted to ask is, how expensive is it to run a medication-free unit compared, for example, to a classical model, to a classical psychiatric ward? How expensive is it?
It costs about the same as an other bed unit in the hospital. Although since it's a small bed unit, it costs as much as another small bed unit. Small bed units are generally more expensive to run than bigger bed units. But the price is somewhat similar to other bed units.
When talking about economics, I can't avoid asking this question, the Big Pharma question. We know that it's not a conspiracy. We have scientific evidence suggesting that there are some biases associated with, for example, people working conducting research with SSRIs being associated with the Big Pharma or big pharmaceutical companies. How much of an influence do you think the Big Pharma has in the problem, or how much contribution does it have in the problem of over-medication, which is real, of course, in psychiatry?
I think Big Pharma has a big role, but I think we all play a role. I think psychiatry also plays a big role. And at the same time, this is a very big discussion. But I think, for instance, the American Psychiatric Association plays a very big role. The introduction of the DSM system back in 1980 and the development of the the third version of the DSM system back in 1980 and the later versions plays an important role because they kind of develop diagnostic categories that are very good to medicate in a way, if you get what I mean. So I think they play a very big role, and it's also to us, for instance, in the drug-free ward, it's difficult when you want to taper down drugs very gradually. The drug industry, they don't produce the kind of drugs that you would need to taper down gradually enough. So we have to buy expensive versions of the drugs from a pharmacy in Netherlands where they produce so-called tapering strips, so that it's possible to taper down at a very slow pace the amount of drugs that you're using. But the drug industry, they're not interested in that. That won't make them any money, and they are not particularly interested in people tapering down, I don't think.
What is your vision? Where do you think the role of psychopharmacology will be in the future? How do you see uh, the combination of medication-based and medication-free approaches to interact? What is your vision? How big do you think these possibilities should be available for the patients? Do you have a sense of how many patients you'll have to work with ultimately in the long run?
I think it's very difficult to say, but I think that, and also it's very difficult to say what the development will be of the pharmaceutical industry. This is not only a problem in psychiatry. I guess it's even more now a problem in other fields of medicine where the prices for some of these drugs are outrageous, and it's very difficult to really see why they should be this expensive, except for making some people very rich. And you see a drug industry that's in many aspects are out of control, and I think it's difficult to say if this is something that it would be possible to regulate in a
Do
sensible
you
way.
feel you'll still have some resistance from not only the big pharma but from your colleagues, or do you feel that the climate is much better right now as compared to say what was happening before 2015? Do you feel that your peers started to react more kind of calmly to the ongoing changes? Do you see that?
Yeah, I don't think some people were seem to be kind of scared of the possibility of having a drug-free treatment program. I don't think people experience what's happening as something that they need to be scared about. At the same time, in Norway, we had a debate in I think it was a year and a half ago in the Norwegian Psychiatric Association. They have this yearly event where we had a debate about this, and to me, it seems that there was a lot more support for the possibility of doing things differently than I would have thought it would be. So I was kind of surprised of the support that we got for trying to develop something that's not basically drug run. At the same time, in Norway, there's a lot of Norwegian psychiatry is somewhat different, for instance, from Swedish psychiatry, from Danish psychiatry. It has a history of a more
Yes.
psychodynamic approach, and it still is psychodynamics is still very highly emphasized in the education of psychiatrists in Norway. I think more so than in Sweden and Denmark. And psychodynamic therapy is, of course, basically a drug-free treatment program, although generally not for people with serious mental illnesses. But it's kind of emphasis on not using drugs. I think that's also something that makes this possible to happen in Norway, maybe more so than
Indeed,
in other
I thought
countries.
also that it was very interesting that Norway is the first country to talk about it, and I definitely think that just the mere fact of the discussion that happened in 2017 is great. I of course also read up on the history of the Norwegian psychiatry and saw that virtually in all periods, ideas of humanization of mental health care were very popular, even in the Second World War period, and if anything, the founders of Norwegian psychiatry, Frederick Holst and Herman Wedelmeyer, were real advocates
Yes,
of the humanistic approaches in psychiatry. So it's interesting that Norway is the first to rebel in a way and to first speak up about this issue. And what we've been discussing with my colleagues as well is that no matter where you stand in the discussion, it's very interesting that the discussion is happening because I think we all agree that just the mere discussion touches upon very sensitive topics of psychiatry. Who should decide? Who
absolutely.
should choose the treatment? Who should be the main actor in these sorts of decision? And definitely, I think for a very long time we listened very little what our patients and their relatives have to say.
Yeah.
What I was wondering about is it's been 2 years since your unit started working, and I just have a very practical questions. When the first reports are coming? When will we read about the preliminary results of your work?
I think the reports will not be good or really coming before we get the research going, which starts this fall. That will follow the patient through the program from this fall. And I'm not sure how far, if it will be possible to make very good retrospective reports with the patient that's been there. But we will look into that, and hopefully 1 or 2 years from now it will be published something from this unit.
We talked a little bit, but there are virtually no guidelines or information on drug withdrawal, on adjusting the medication. Of course, there are some studies that attempted to analyze that, to analyze patients' experience, doctors' experience. But is there any literature that you can recommend for clinicians, for example, to study this matter?
Well, we have this American user organizations has made this. I don't know if you're aware of this one. It's probably also published in Sweden. It's published by a guy who works, or the author of this is a person with user experience and also experience as a therapist, and this seems to be quite useful for patients to use or to look into. And also there are some there's the psychiatrist Folkmar Aderhold. He has published, it's on the net, you can find it, guides to reducing psychotropic drugs. It's where it tries to sum up some of the research that's been done. So this will be things that we have tried to utilize, but we try to very much discuss with each patient, because very many patients will have an experience of trying to drop the drug treatment, or trying to get away from drug treatment, or they will generally have tried to taper down themselves, or just quitting, and they will have a lot of experience, and we have to relate the way that we collaborate around tapering down to their own experiences.
It's very important that you are bringing this up, and of course Norway is pioneering the medication-free approach in a scientific context, at least. But you were also in the same situation that the rest of the world is perhaps right now, when you were receiving questions from patients how to adjust their medications. How did you react to these comments, to these questions, when their relatives are asking you whether I will ever be able to be free from drug medication? What did you tell the patients and their relatives?
We will generally say that it's hard to know, because we have seen patients that have tried to taper down or to quit medication themselves, that has come back and got their problems back, and we have seen patients that has managed to do that. So we will see that this will be something that we have to find out, and it's also a question about what's acceptable for the patients and for the patient's family, and what is it possible to live with, and things like that. But it seems to me that when it comes to medication, we know that not all patients have a good use of antipsychotic drugs. We know that there's a big proportion that doesn't really get good help from these drugs. It seems to me that in psychiatry, to a large extent, we tend to still give patients the drugs. So when we have a patient that we give one neuroleptic, one antipsychotic drugs, and it doesn't really give any help, or doesn't really work the way we see it, what do? Generally, we will try another drug, or we will give a little higher doses. And it's very difficult to find out, well, maybe this is a patient that doesn't really where the drugs doesn't really work. Because the patient will generally just be more drugged, and it'll be very often drugged into such an extent that the patient is getting kind of knocked out, or lazy, or just sitting there, and then you will say, well, at least he's not acting like he used to, he's just sitting there. But he might not be better from his problems, really, but he might act differently, and that might be what what you're looking for in one way, but it's hard to say. It is that we don't really know.
At least they shouldn't do that.
Which patients are we giving
they
drugs?
shouldn't have to do that on their own without discussing that with the psychiatrist.
Yeah.
Interesting that.
So I think that might be some of the patients that we see, the patients that taper down the drugs and they didn't really need it. That's one perspective. They didn't really need it, but nobody had ever found out. So we have had patients that have used quite big doses for years and years, and they come and taper down, and it seems that they didn't really need it. They were just used to it.
We all had this experience working with these patients, and they get to a new hospital, they get another huge combination with clozapine and some other drugs in really severe doses, and we still don't know what to do with them. Actually, just a few days ago, I interacted with my ex-colleagues from Russia, and they are planning on starting a project on attempting to reduce the pharmacological workload on this really severely resistant patients. So they are trying to explore different strategies of how to do that properly, what could be the subpopulation of these patients who could perhaps do at least not worse once they start reducing the load of the pharmacological treatment. So I do think it's important to keep the studies going. Our time is almost up. We have some time for Q&A, and I did get some questions, and I'm not surprised that there are some people asking about psychedelic assisted treatment because I mean, I've been collaborating on this matter with the Imperial College group, and I know that you've been asked these questions multiple times. So, for example, during the debate that happened in 2017, and you also talked a little bit that the current model of psychopharmacology implies that person takes medications on daily basis, and perhaps there is a little bit of conflict of interest between pharma industry and the patients once they, because of course financially it is in interest of a pharmacological company for patients to continue taking medications, whereas psychedelics offer a very different framework. So some call it a single shot intervention, which implies one or very few psychotherapeutic sessions in the context of a drug-assisted therapy. And I was wondering, what is your stance, what is your position at the moment concerning psychedelic-assisted therapy? Do you think it has future? And I can't help but notice some of the similarities when talking about psychedelics and the medication-free treatment that you're currently trying to study. There are very similar ethical issues. There are very similar economical issues. Both approaches have some questionable past when these approaches were not implemented properly. But I'm mostly wondering, what is your current position on the rationale behind psychedelic-assisted therapy?
Yeah, we at least the drug-free program that we try to develop, essential part of that is that we don't want to manipulate people's brains with chemical substances. I mean, that's a kind of a goal. So within this program, at least now, there's not been raised a question about is this something that we should look into or something that we should deal with? We have just started a debate now about yoga. Should we go into yoga? Which some people say, well, the experiences that you can get from some kind of yoga or some kind of meditation might be similar to what you get from psychedelics. So I think our approach would be more in that direction if we are going into a direction like that. But within the field as a whole, I think there might be some possibilities for psychedelics. Not at least when it comes to substance abuse, there might be some possibilities, I think. But I personally, I don't know enough about it. There are extremely many things possibilities that we have when it comes to what should we develop as a part of a drug-free program. I didn't talk much about what we do, but we relate a lot to a recovery perspective, and we have recovery workshops ongoing every day in the ward. We also have physical training, kind of real physical training. We have art therapy and things like that. So we have just gone into certain things that have proven to have some effects on people, or have some good response with people with serious mental illnesses. Although the research that's been done with these different approaches, they're generally also conducted with patients that are also using drugs. So it's difficult to say, but that's part of our program now.
Related to that, I already mentioned that both psychedelic-assisted therapy and the medication-free treatment they both have some questionable past. I'm referring to Kingsley Hall, which also received very different perception from public and from the scientific community. And same for psychedelics. These drugs were also abused. And whoever asked the question about the psychedelics, I just wanted to mention that one should be particularly careful with psychosis spectrum disorders that Magnus is working with, because right now they are filtered out from all of the studies that employ. We are talking mostly about their application for non-psychotic patients suffering from anxiety disorders, from depression, from non-psychotic depression. So one should be very, very careful with the population of people suffering from schizophrenia spectrum disorders.
Yeah.
But what I was wondering is, considering that both approaches have difficult past, what should we do to avoid when implementing medication-free treatment, not in order not to repeat perhaps the errors of the past? What are the aspects where we should be particularly careful with? Can you comment on that?
Well, I think it's the idea of doing research on what we're doing. That should be something that we should do, and we have really tried to get that going here. But it's been very difficult to get it financed, because it's not like it's difficult. It can't be understood as an ordinary what should you say, treatment research. It's not like we have one group like this and one group like that, and this one group is giving this, and because we are tailoring individual programs to each patient. So it's that's one of the reasons it's been difficult for us to get some kind of research financed, and we are short of staff to really do good research on the patients that we have. So, but I think that should be done with new programs like this. And I think also the question is also what is the worst that might happen in a way. And I think some things that you are doing as an experiment or as a tryout or whatever carries more risks than other things. And to me, the risks of not treating patients with neuroleptics compared to treating patients with neuroleptics is not very big. The research that shows that that you get into long-term problems with if you don't start treatment in neuroleptics early, I don't find that as a solid body of research in any way. So there's just as much research showing that you get into troubles over time when you treat with neuroleptics. So I think this is a kind of a risk-free thing in that respect. But using other kinds of drugs, it might carry more risks with them, and that will also be something that we have to take into consideration.
Thank you so much, Magnus, for your time. I wish you more funding so you could continue your line of research.
But we're getting it now from this fall. I think it's done.
And we all look forward to hearing more from you once the result come to be published. Thank you so much.
Thank you.